Hello there and welcome. Now we are about to start part number 4 of our PMHNP crash course review. My name is Dr. Lopez. I want to emphasize one more time that every single word, every single phrase is important. Pay attention to the examples. Make sure you pause on each slide and write it down. You want to write it down in a way that makes sense to you so you can have this as your note. Once you watch this, the crash course review, it should really test within 7 days. Now, I want you to rewrite everything so that it works in a different part of your brain and you memorize and most importantly, understand the questions and understand the content. Once you finish this crash course review, make sure you take the test that we have ready for you and keyed on the questions that you got incorrect so that way you have a better understanding of this content. So this one is full of information. It's a little bit longer than most, but let's get started. All right, so this is our roadmap. As I mentioned, this is a little bit longer than the most of the content. I usually break it out in fewer videos, but since it's the crash course, everything here is important. So we'll be covering a lot of topics. All right, so let's start off with the reactive attachment disorder, right? So think of reactive attachment disorders of those kids that have been uh, in foster homes. So which means they didn't develop an attachment with the giver. So therefore they develop a dysfunction in early childhood between the caregiver and the child. So they didn't have the bond of security. So once this happens, right, say they have now reached the comfort or support of the caregiver. So because of that, they have a lack of emotional regulation. As you can imagine, they would have limit affect or episodes of unexplained uh, irritability, sadness, and full and fearfulness. After all, they see the world as a hostile place, so they have a problem with attaching with others. Okay, but keyword here: foster care and the dysfunction in early relationship. Write it down every single topic, guys. Okay. Generalized anxiety disorder, very common in practice. You most likely see a question is on your test. Understand the most important aspect here is that the person must have an anxiety that has lasted at least 6 months, right? And that can be shown as difficult controlling worries, restless, feeling keyed up on on edge, being easily fatigued, difficulty concentrating, mind going blank, irritability, muscle tension, sleep disturbance. Can be difficult falling asleep or waking up in the middle of the night or even waking up feeling tired, right? Keyword, generalized anxiety disorder, at least 6 months. Okay. Now, I want to just highlight this one more time here. Most of the time, I say that on the test, you will not get a question that gives you a full diagnostic criteria that will give you full symptoms, right? Oftentimes, it is, let's say, major depressive disorder. You need 5 symptoms for over 2 weeks. They might give you 3 symptoms and they say for some time. It doesn't really specify how long. So in that case, you're looking at the most likely diagnosis. However, on generalized anxiety disorder, it's most likely they will give you a time frame of 6 months. Okay, so pay attention on that little difference there. Now, medication that can cause mania and depression, right? We have gone over them when we know which ones they are, but just want to give you some examples here. So, Flonase is a steroid. Steroids can cause mania and depression, okay? It's used in patients being treated for mood disorders, sometimes like lithium, Depakote, or Torgadol. Assess which medications cause the unwanted effect, okay, the symptom. What am I talking about here? It's kind of hard to key in what you need to know. But the point is, if a patient is in a mood stabilizer and they are using steroid, okay, your action is to increase the psychotropic medication or contact the the PCM to adjust the medication, see if the Flonase can be discontinued. If it can't, then your action is increase of psychotropic medication. Another example, Lexapro and Interferon, right? So if the patient returns later and stating that the dose is ineffective, then you can increase the dose of Lexapro. Because here we're saying, hey, Lexapro worked well. The patient later was added Interferon. So Interferon is countering the Lexapro. So your action is to increase the Lexapro. Now, example of steroid and Abilify, for example, right? Because steroids can also cause psychosis. So in this example, you may need to increase the dose of Abilify to adjust for the steroid. Takeaway. The main takeaway of this slide is adjust the psychotropic medication due to the drug interactions with any of the above. Okay. Now, for example, let's say that someone is on a SSRI and they come to you, you started the person on SSRI, 4 weeks later they come back. The symptoms is better. Would you decrease the medication? No, no, no. The key point too, if there is only time frame, you need to wait 8 weeks before you make a change. Well, what if the GAD score decreased for anxiety? It was 14, now it's 2. Are you going to decrease the medication? No, no, no. You keep it the same time frame as long as it is for 8 weeks. Not necessarily pertaining to this slide, but I just want to highlight that very often ask the question is when to change the medication. Now, panic disorders and panic attacks. There are two different things and you treat them differently. Let's start with panic attacks. Panic attacks is one of very few episodes that reach peak within minutes, right? It's explosive. And then they have symptoms of impending doom, chill, nausea, chest pain, increased heart rate, or blood pressure, right? So it is very uncomfortable feelings. If someone says, I don't know if I ever had a panic attack, most likely they never had one because if they did have one, they wouldn't know what a panic attack is, okay? They would avoid going back to the same places or would avoid going to any locations that it has occurred. Now, when the panic attacks multiply several times, it becomes a panic disorder. So now a disorder is the multiple panic attacks. Those who suffer with panic attack often experience recurrent, unexpected episodes without any appearance cause. They come from nowhere. Thus, it becomes a disorder. So, what medication are you going to use? Well, SSRIs such as Prozac, Zoloft, or Paxil are often prescribed. Again, it's not just the highlighted content you need to know. I am putting here every single line you need to know. So you need to know the difference between panic attack, panic disorder, how to treat panic disorder. You give them an SSRI. Well, can you give a propranolol? Yes, you can give a propranolol too because it decreases the heart rate, makes the patient feel more relaxed. However, propranolol is contraindication with asthmatic patients, so patients that take inhalant of any kind. They have a difficult breathing. How come? It is a bronchospasm. Patients can get into bronchospasm due to the beta blocker, propranolol. So you need to be very aware of that. If you prescribe propranolol, ensure the patient doesn't have an asthmatic condition that would be contraindicated. Okay. Now for the panic attack, also you could give also propranolol. You could also give an SSRI or even a benzo. Of course, we want to stay away from benzo as much as possible, right? Starting with a safe dose of SSRI is a good way to go. Now, bulimia, right? Often questions will ask you bulimia and anorexia. First of all, I want to do the definition of bulimia, which is a periods of eating large amounts of food followed by an attempt to prevent weight gain. This prevention of weight gain can be due to induced vomiting, misuse of laxatives, of fasting, or excessive exercise. So a problem here is with the self-esteem, right? Is overly influenced by the body shape and weight. Patients often will have a range of a BMI. Usually, the body mass index is normal or above normal. So this is very different than anorexia, which you have a lower BMI. Okay, so you can use the bulimia mnemonic to kind of help you. It's called binge, which is binge episodes, inappropriate compensatory behavior to avoid weight gain, a normal weight or overweight typically, and the feeling of guilt after binging, right? And the E is the excessive concern with body shapes and weight. Okay, key point here is bulimia often have a normal to a slightly higher weight compared to anorexia. Now, anorexia, right? So they'll have a very low body mass index. They may present with amenorrhea, emaciation, which is very thin person, bradycardia, and hypotension. So the heart is low, the blood pressure is low. You may need to hospitalize the patient when the BMI is less than 15. Well, why? Because your electrolytes, the patient's electrolyte is can be dysfunctional. This can become problematic. The heart rate can drop, the blood pressure can drop. Now the patient can faint and get hurt. Well, let's say a scenario in which you have a patient that's 15 years old and BMI is 15 or 14, whatever, and you do a consultation with the primary care provider, right? So your action is to do a consultation with the primary provider and ask for a admission. Okay. So now let's say that the mother says, "Hey, I don't think she needs to be admitted. I've been taking care of her. She is fine," and insist the patient not to be admitted. So your action now becomes a protective action. So now, if the mother refuses to admit the patient to allow for an admission, then your action now becomes to safety of the patient, in this case called CPS. So understand that you have an option to collaborate with a PCM if that's one of the answer choices. If it's not, try an admission if that's one of the answer choice. If the mother gets involved and says, "No, I don't want to," then you have to care for the patient first. And that can cause a dilemma, correct, between the mother, the daughter, and you. However, you're looking out for the patient's safety, so you may be necessary to call the CPS. All right, autism spectrum disorders. So neurotransmitter involved GGDNS. GGDNS is GABA, glutamate, serotonin, norepinephrine, dopamine. So DNS will be the dopamine, serotonin, and norepinephrine. Okay, plus the GG, which I'm referring to glutamate and GABA. So write this down. GG plus DNS, dopamine, uh, serotonin, and norepinephrine and serotonin. So, what is autism disorder? So, autism disorder is very known for social communication that's lacking, deficit of social communication, and that goes into all areas of context. It cannot just be social interaction at school that's like it's really everywhere. The only time they may have a normal social interactions with the parents. So oftentimes people say, "Hey Johnny, come over here," and Johnny doesn't look. It does not respond by the name. Use limited nonverbal communication behavior for social interactions. Makes little or no eye contact. Demonstrate repetitive behaviors such as line up, stacking up, organize objects, or toy in a very peculiar way. They like routine. Okay. What is the broken mirrors theory? Okay, it's a hypothesis. The broken mirror theory is a hypothesis that autism spectrum disorder are due in part to a dysfunction in the brain in the mirror neuron system. Okay, so basically, the theory suggests that because the mirror neurons are involved in the ability to express empathy and understanding the intentions of others, a malfunction or impairment within this system could contribute to the social and communication difficulties often experienced by individuals with autism. This theory, while intriguing, is one among several and is not without controversy within the science community. However, you need to know for the test. That's it's kind of like been out there, and people talk about this broken mirror theory. So, in normal person, one would be able to express empathy and understand of intentions of others, and this is lacking in those with autism. Therefore, the broken mirror neuron is dysfunctional. Okay. Well, I am going sort of fast. It doesn't mean something's being left over. So what I'm counting here that every slide you're stopping, you analyze and you understand, and then you proceed to the next slide. Okay. Now let's talk about child information or childhood information because they are all over the place. There are too many to list, but I kind of pick up some here that I think it's important. Okay. When the child exhibits symptoms of irritability, mood swing, and a depressed mood, it's important to assess in this situation, right? So, how would you assess a child that presents with mood swing, depressed a mood? Would do a mood questionnaire to gather more information. You do a mood questionnaire. So this is like in the case of children that have a like irritability or like a bipolar like symptoms, which we never diagnose a kid with bipolar, right? So, but they express similar dysfunction, but in a childhood. So you do a mood questionnaire. Same thing if is an adult and they have bipolar like symptoms, you do also a mood questionnaire. So if the mother is concerned about that child nightmare, totally different topics, but I put it in one slide. If one is concerned about nightmares, what you need to do is reassess for genetic factors. Why? Well, very simple. It's likely that someone in the family has also nightmare. Those symptoms should go away, but it's important to reinforce the teaching and provide to the family that it's very genetic. Okay, so you want to reassure the parents and provide them with supportive guidance in addressing the issue. Okay. Now, another issue that often comes back to children, males, right, adolescent, is an enlarged breast in boys, usually between the age of 7, 9 to 16 years old. So, what you want to do is not prescribe a medication. It's not get an MRI. It's not none of that because it's common condition during puberty. So it's common for boys to have enlarged breasts and they should go away within 6 months. Okay. So do not do something extreme when you know this is a normalcy of life for boys. Okay. Self esteem. How would you increase self esteem in children, adolescents? Well, one way to do that is to exercise, uh, provide guidance and encourage exercise. Exercise in children help promote resilience. So, how to increase self esteem? Exercise is a good choice, allowing them to have more confidence and friends and exercise and doing group work is important. So, exercise increases self esteem. If you get a child that has gone through some trauma, right, and they have a very restrictive narrative, so they're not able to talk a whole lot, they're very closed. You want to do a close-end questions. So oftentimes we are very drawn to open-ended questions, right? If I ask someone, a child that have very close narrative, that's very withdrawn, I better ask a close-end question. At least I get something than to force someone to speak a whole lot when they are not able or do not want to speak. So, a close-end questions for those children who cannot construct a narrative before contacting the parents, right? So, how are you, or what has caused, why, yeah, very close-ended questions to start off, right? And then you contact the parents to get more information. Okay. Something else that really throws people off, that you see it often comes up because it's weird in a way, is the feral door, the phallic stage, right? So the phallic stage, if you look back into our lessons, you see that it's normal. It's normal for 3 to 6 years old to play with themselves. This playing is not a full blown masturbation in any means. It is basically that child exploring his or her body in a way by touching, feeling. It's not necessarily a sexual action, but it's kind of like, oh, I have this, oh, kind of touching, right? So it's in a way difficult for most of us to understand, but no, this is a normal act according to the Fyodor theory, and that falls under the phallic stage. Okay, so don't be thrown off. Phallic stage, 3 to 6 years old, is normal for girls, boys to discover body parts. So now let's talk about child safety examples here. Remember, we are talking about those examples so they can be anchored when you see a similar situation. So every example, everything that's being said is important. Do not skip any lines, right? Many of us, oh, I've seen a lot of students that have missed the test because of one question. So you need to fight for every question. You need to fight for every question because you do not want to score a 347. You missed one question or so. You could have got a better result. So please stay tuned and get every single point that you can. That being said, on a test, you will find situations in which you do not know the answer. So simply use the strategy that we talked about by striking through, selective review, and going back to those questions later. Now, let's go back to the child safety examples here. If a mother has reported a concern of sexual situations involving 5 years old and old daughter and her brother, right? So the brother touched the daughter or has taken some kind of sexual activity or has touched the daughter inappropriately, and the mother reports this situation to you, your first action, in fact, any first action that you always should take is safety first. And what does it mean in this case? Well, your action is to encourage the mother to stay with the child constantly for safety, such as do not leave the child alone, right? That's your first action. Your first action is not to call the CPS because it could be some time until the CPS arrives. So your first action is to consistently encourage the mother not to leave the child alone. Then, after that, you can consider child support service for immediate interventions. And obviously, you want to arrange for crisis therapy sessions for the affected family, right? So, if the brother and the sister, they both will be affected, the parents will be affected. So, you definitely want to arrange for immediate crisis therapy sessions. So, first, ensure the mother stays with the child, CPS next, and ensure immediate crisis therapy sessions followed by. Now, other children or important information to keep in mind, right? Sometimes children have bad wedding situation, right? They just can't control. So here, depending on how the questions may present, one option, if we ask for pharmacologic intervention, know that demopressin is used to treat bad bedwetting, right? Demopressin is used to treat bedwetting. How? while it reduces the urine production, therefore it helps relieve some of the symptoms. Options two, let's say a child is defecating at night or something along those lines. So you could establish also a bad uh, potty training. Potty training can be established and it helps with that as well. So if the option is for a pharmacological intervention, pick that. If it's for non-pharmacological intervention, you may pick scheduled potty training. Okay. Another example here of infants safety example. Let's say that you have a baby that comes to your office for whatever reason, accompanied by the mother, and you notice that the baby had this high pitched chill cry, and may indicate to what? That's an indication for increased intracranial pressure. If you hear high pitched chill cry of a child that cannot be calmed down, that despite of the mother holding the child and the child just doesn't calm down, so that can be a increased intracranial pressure. Okay, children, they often have lead poisoning. When the child have lead poisoning, whether it's by eating a paint from the wall or something that has lead poisoning, right? You will see developmental delays, learning difficulties, irritability, lose of appetite, weight lose, and fatigue. So pretty common, okay? So make sure you know the signs of lead poisoning, know what the high pitch chill cry is, and know the mechanism of action of a demodepressant to reduce urine production, thus being helpful for bedwetting. Also, for bedwetting or defecating on the bed, a potty training schedule can be helpful. Now, more things about children. So, medication safety, right? So, when it comes to medication safety, you want to always assess for the history of a possible iatrogenic, iatrogenic, which is side effect. Anytime you hear iatrogenic, you put it equals to side effect. It's the same thing. So you want to ensure safety by assessing the medication for risks of iatrogenic, which is the same thing, side effect. Now, let's say that you have a patient that's doing well and taking Lexapro. Boom, FDA issues a severe warning for that medication. Okay, your job is not to discontinue the medication immediately, but you will assess the advantage versus the potential threat of applying this drug, right? So you assess first. You do not discontinue the medication just because the FDA issued a warning. So good example here is that we know that SSRIs have a warning for children under 26 years old and adolescent. They have a risk of suicidal ideation. So if that warning comes back, you don't take the child off a Prozac. Instead, you assess the risk benefit and you decide if this is a good or not for the child specifically, right? So you want to consult the patient before discontinue of the medication. Off-label use. This should be a different slide here. Off-base, off-label use. You want to do few things. You want to communicate the pros and cons to the patient and usage of proper recording, so documentation. You want to document that you have told the patient this is FDA, this is not a FDA approved medication. You are using this for uh, a off-label use. So example here, trazodone. I use trazodone all the time to prescribe for, not trazodone is antidepressant, but I use for insomnia. I I like to use that for those patients that have major depressive disorder and they can't sleep, they have insomnia. I will add the 50 milligrams of trazodone in addition to an SSRI. Another example is Atarax. I use Atarax for patients with insomnia, right, which is a antihistamine, but this is off-label use, right? So for the off-label, I have to document and say, hey, this is an off-label use. I I use it for X, Y reasons, right? So it's very important to communicate this is the off-label use. So you let's say that you encounter a situation in which your colleagues are using off-label use, and before you blame them, you want to find the research to support any off-label use. So questions that I ask you to go ahead and report, go ahead and um, tell the supervisor usually are incorrect. So you want to look for research of those off-label use before you take an action. So assessing first, right? You want always to clarify patient education. So assess the patient current understanding of their medical conditions or medication. So before you teach someone about, let's say, diabetes, if that's the case, or metabolic syndrome, ask the patient what do they know about metabolic syndrome, or what they know about this certain medication, and then from there you initiate your teaching, right? Infant lose in grieving. This is very important, right? Because grieving is an individual process and everyone grieves differently. So you want to allow the family sufficient time to grieve. You want to allow the family sufficient time to grieve. And how is that? Well, you want to avoid dictating someone how to grieve. You don't tell nobody how to grieve. For example, here, examples are important. Do not suggest a mother that she should stay busy to forget about the child, the loss of a child. Okay, the mother, what you want to do is encourage the mother to you do a brief support therapy, allowing the mother to grieve however she wants to grieve. Okay, and for those with the grieving process, troubled grieving process, a stable family unit can facilitate a easier adoption of the grieving process, right? So if you have a family that the husband and wife they coordinate things well, they have a stable relationship, it's a lot easier than having a unstable, about to get divorced, and then a child passes away. So it makes sense. You want a stable family can facilitate uh, easier adoption of the recent grieving process. You can do for grieving process and infant loss. You can do um, psychoeducation. Psychoeducation, if that's an option for any question, is likely to be the correct answer. Okay, so be very aware. Psychoeducation is huge. So psychoeducation, you can offer group supportive therapy, and group supportive therapy works so well for any kind of trauma. For example, for children and adults, rape, sexual assault, um, PTSD. So group therapy is a wonderful option, especially with children because they bond by knowing that others have gone through the same trouble and they're dealing and learning how to get better together. So you can also offer not breed but brief supportive therapy there. Okay, misspelled brief. Okay, delirium. Delirium is fast. Delirium is very acute disturbance of level of consciousness, cognitive, and attention. So delirium is fast. It's faster than dementia. It's faster than major depressive disorder. You don't get delirium within months. You get delirium within hours. Right? If you have someone that's having delirium plus psychotic symptoms, you may use Haldol. Delirium plus psychotic features, you can use Haldol. it's very, very common for the older adult to have delirium when they have a urinary infection. So your action is to conduct a urinalysis to determine with culture and sensitivity. So you get the UA with culture and sensitivity, because then you can refer and initiate the antibiotics that will possibly help with the infection that's going on. Okay, so your action is to get the UA with culture and sensitivity. Be very aware of those with delirium in older adults. You know it's delirium because it's an acute occurrence, and you get a UA to help the process here. Dimension. So if delirium was very fast, dimension is very, very slow. It's a progressive mental decline. Dementia doesn't happen within a week. Dementia doesn't happen within a few months. It's a progressive over the years. Usually dementia goes over the year, or at least the normal dementia process. And then you see problems with irritability and personality shifts, right? So the person doesn't know the, the daughter or the husband, and they act differently. So usually dementia is a it doesn't regress, it only progress. However, there are times in which the dementia can be due to a deficit of B12 and folic acid. Well, if one of the options is to collect a B12 and folic labs, that sounds pretty good, right? Because if I can correct the B12 and the folic acid, I could decrease the dementia progression. Certain case even completely change the scenario here by getting a patient a B12 and folic acid dose. So that if that's one of the options, be very aware that could be one of the answers. Okay. Now, dementia happens over time and usually progressive, and you are divided between cortical and subcortical. You need to know they are divided between cortical and subcortical dementia. When you hear cortical dementia, that's above the subcortical. When you hear cortical dementia, think about language and memory deficit. Cortical dementia, language and memory deficit. And here I'm giving you example of language. It's aphasia, and memory, right? Would you be amnesia? So aphasia and amnesia, cortical dementia. If you the symptoms are aphasia and amnesia, or language and memory, same thing. That's a cortical. Most likely, this is a cortical dementia. Example of cortical dementias: Alzheimer's, dementia of Lewy body, and the frontal temporal lobe dementia, or also known as Pick's disease. Okay, these are a typical example. So I give you three examples: Alzheimer's, Lewy body, and frontal temporal dementia. Okay, so let's start with Lewy body. Lewy body, I like to say a joke here, right? When I hear Lewy body, I say I'm seeing things. I'm seeing things. What I'm saying here is visual hallucination. The example of Lewy body is visual hallucination, and that because of the occipital lobe is being affected, even though the eyes are pretty normal. So Lewy body is an example of visual hallucination. And do not give antipsychotics. So this is an example that Lewy body, you do not give the Haldol because it will make things worse. You do not give any antipsychotics if you have diagnosed the patient with Lewy body dementia. It's part of the process to have visual hallucination. Again, Pick's disease, also known as your frontal temporal dementia. If the patient have a frontal temporal dementia, you would expect personality change, behavior issues, and language, right? So they have language issue because it's cortical. They have behavior and personality issues. Every time you hear frontal, I want you to think about personality change and behavior change. That's a must, okay? So the frontal cortex has a lot to do with your personality. Someone that was well behaved, they are no longer behaving well. Someone uh, that have may have language difficult. That's also because of your expressive uh, bronchial area is being affected, right? You weren't able to speak well as you did before. Now, as we move on to the cortical uh, dimension and gets into the subcortical, below the cortical, then we see symptoms of motor disorder, okay, plus depression. So the cortical, I said language and memory. So subcortical, I am saying motor and depression symptoms, okay? So the subcortical is motor and depression. So the motor can be lack of coordination, tremors, ataxia, dystonia. That's all motor, right? Looks like EPS symptoms, doesn't it? So the depression can be irritability or apathy. So if you look at the question, they give you symptoms of depressive plus motor. So you know this is subcortical. So if the cortical, the three examples that I gave you was the Alzheimer, Lewy body, and frontal dementia of Pick's disease. Now the subcortical, I'm gonna give you the three more example: Huntington's disease, Parkinson, that makes sense, modem, and HI AIDS dementia or HIV dementia. Okay, so that being said, when we talked about HIV related disorder, right, or dementia here specifically, you have a cognitive deterioration. The brain is not working that well. You have a motor abnormality because it's subcortical here too, right? So you have a motor uh, Parkinsonian-like abnormality, and you have a behavior change. Okay. Now let's talk about here for one quick second. That's not on a slide. If you get a patient with HIV dementia, your action is to get the viral load and and suggest that the patient take the antiviral, right? Because we can give any of the classifications of medications for dementia, it's not going to make it better, right? So your action is to collect the viral load, especially if the CD4 is less than 200. You want to fix that, or at least prescribe to collaborate with the specialist in this area. So getting a CD4 level and encourage the patient to take his or her antiviral load because that will help with the HIV symptoms. So we said subcortical Huntington's disease. So Huntington's disease, the future of motor abnormality is huge here, and psychomotor slowing down, depression, and psychosis. So this really fits well with subcortical. We said motor and depression. So you have motor and depression with Huntington's disease, but now it adds a little bit of psychosis into it. Okay. So know that psychosis and agitation in various dimensions type is kind of not normal, but they can occur. Okay, they can come together. So how would you manage? What are your recommendations for patients with dementia? So your first recommendation is to use non-pharmacological intervention. Think of this way: is use the least amount of medications possible or least amount of intervention to do the job. Here we're going to start with the non-pharmacological intervention, followed by a atypical antipsychotic if necessary, right? So I said with the delirium, right? You can use a slow dose of Haldol if it presents with psychosis. Here for dementia, you want to encourage a clock in the room, encourage family members to be close to the person before you even attempt a restraint, right? So what's the least amount of force that we can do for demented patient to ensure maybe a one-to-one sitter? That's a much better option than giving a antipsychotics. Now you tried everything and you decide that is antipsychotic is the appropriate action due to safety concerns of the patient, then you want to use a atypical antipsychotic if you must. Okay, very important. As we move on between dementia and major depressive disorder, these two conditions look somewhat alike. So you have to distinguish if this is older patients with dementia or is it the older patient with major depressive disorder. And by the way, major depressive disorder is also called pseudodementia. Okay, pseudodementia is the same thing as major depressive disorder. So one is commonly mistaken for the other. Okay, but let's take a look on the difference here. Dementia patients typically proceed with a history of gradually declining function. As I mentioned, this is months and months of declining function, right? Every month, usually getting worse, but by very little. So you want to use a scale to compare this month and 6 months later, right? So you'd see a the MMSE, you'd have a decline below the number of 24. Remember, the MMSE, higher numbers are better, lower numbers are worse, right? If you have a very low number, it's likely to be dementia. And you want to use the scales when possible for whatever condition you're treating to monitor over time your treatment. So again, dementia takes a long time. So dementia patients, they are known for trying to answer the question. Even if they don't know, they'll confabulate, they'll create an answer for you. Comparing to a MDD, they'll simply say, I don't know, unclear, I don't want to talk about, I don't want to answer, right? While while patients with dementia, they'll confabulate. So acute onset, obviously here, is not acute as delirium, but is more acute than dementia. So dementia long term, major depressive disorder may be weeks or months, but nowhere near to the year time frame of dementia change. Okay, so this is how you differentiate both of these conditions. Tests are likely to make this very confused. So if you know that dementia confabulate, major depressive disorder say, I don't know. Dementia is over progressive months of time. Major depressive can be weeks to months, but it's not as fast as delirium. Risk factors for osteoporosis, right? It can be smoking, excessive caffeine, insufficient weight bearing, exercise, right? Lack of exercise in general, aerobic conditions, and the lack of a diet rich in calcium and vitamin D. So know that insufficient weight bearing exercise is highly important, and smoking, caffeine also kind of doesn't help osteoporosis, and the diet that lacks vitamin D and vitamin C. All right, rheumatoid arthritis, right? Rheumatoid arthritis. So know that's associated with the elevated erythrocyte sedimentation rate. So what does elevated erythrocyte sedimentation rate? What does it tell you for sure? Well, it doesn't tell you anything, but it tells you that globally speaking, there is an inflammatory process happening. So, since this is an autoimmune disease, so you would see the inflammation process it's happening and is shown by having elevated erythrocyte sedimentation rates, which indicates inflammation. Now, as with any inflammation process, your autoimmune diseases, right? What happened is you have an increase in the level of cytokines. With autoimmune disease, you have an increased level of cytokines. Two important points here is the elevated erythrocyte sedimentation rate and the increased level of cytokines for any autoimmune disease, not necessarily pertaining to rheumatoid arthritis in itself. Okay, the limbic system, right? There are various parts of the limbic system, the thalamus, which I didn't even put in here. Well, I didn't because we are going through the high yield crash course PMHNP board certification. If everything is in here, then nothing is important. But let's start with the thalamus, just below the hypothalamus, just below the thalamus. Then its key roles in function that includes appetite, hunger, thirsty, water balance, circadian rhythm, your sleep, right? Body temperature, libido, hormonal regulations. So you can think of this. I like to use the acronym what the heck. W for water, H for hunger, A for appetite, T for temperature, H for hormones, and the the E is for sex, libido, and the C for circadian rhythm. I think this acronym works very well. You should associate with the hypothalamus. Very high yield, the next three, super high yield, amygdala, responsible for aggression, fear, anxieties, emotion, and the sense of smell. When you get an old cooked meal, and if you had a good childhood, like I had a good childhood, and I would go to my grandma, and she would bake me some oatmeal cookies, and I smell now the oatmeal cookies. It takes me back the good memory that I had with my grandma, right? So amygdala is responsible for connecting your older memories into by the sense of smell to those places that you have stored in your memory, right? So sense of smell is amygdala. When we talked about amygdala, it says fear, aggression, and anxiety. Very important. Now, the hippocampus, right? Think about a hippopotamus that has a big head, and the big head is for storing short-term memory into long-term memory, short-term memory into the long-term memory. But guess what? It has also a lot of implication with the medulla. They kind of look similar, right? So here the key point is stress, stress, stress. The hippocampus has to do with stress. Didn't say fear. It didn't say aggression. It said distress. Okay, learning and memory. So it connects your emotions with stress. Stressful event is the hippocampus, not the amygdala. Stress is the hippocampus, not the amygdala. Okay. Now let's talk about the lobe here. Well, it doesn't really falls into necessarily the limbic system, but the anterior cingulate. That's your part of your frontal lobe, right? So as part of your frontal lobe, it mimics the function of the frontal lobe, which is decision making, empathy, impulse control, and emotion. So the anterior cingulate is responsible for decision making, empathy, impulse control, and emotion. And finally, you have the cerebellum, right? So think of the cerebellum as the balance, right? And posture. If one has taken way too much alcohol and is driving and gets pulled over by the cop, they are likely to have their cerebellum affected because they don't have the balance. They cannot do the fall figure as they stand up. So that's your cerebellum responsible for your balance. If that's affected, the patient would have trouble with posture and balance. So very high yield. We have like s- five super important points here. Hypothalamus, amygdala is the smell, bringing the emotion, aggression, and fear. Hippocampus, think of the stress, learning, the big hippo, the memory. Then we talked about anterior cingulate, which is responsible for your frontal lobe, like symptoms of functions, decision making, empathy, impulse control, and emotions. And think about the cop pulling over someone that had way too many drinks that get you to a cerebella, which is impaired balance and posture. Well, let's move on to neurotransmitter. This is super high yield. I think we learned about this neurotransmitter even when we were taking our BSNs, right? And I'm pretty sure you've seen this in your tests in your schools. Again, I don't care where you came from or what school you attended. They talked about the norepinephrine, serotonin, dopamine, and acetylcholine. Where are they made? Very important. So let's talk about the neuroepinephrine. Okay, it's produced on the lucus coeruleus, and the medullary reticular formation. So two places, lucus coeruleus and the medullary reticular formation. Serotonin is made into the Raphael nuclei of the brain stem. Raphael nuclei of the brain stem. So it's in the brain stem, and the portion is the Raphael nuclei. Is for the serotonin. Think of someone named Raphael, okay, and associate that with the serotonin. The dopamine is made in three places. The VTA, which I like to say a very tired addict, because it's associated with the reward pathway. So dopamine is the VTA, very tired addict, because it's associated with the cocaine and things like that. That is the reward, the feel good sense. It also made it in a nigra. It's also made in a substantial nigra. Okay, substantial nigra, and it has to do with movement. So it kind of makes sense, doesn't it? Those people that have the nigrostriatal pathway, right? When they have a lack of dopamine, they have an increase in acetylcholine, and they will have motor movement. So dopamine, right, is made in the nigrostriata and has to do with the motor movement. Also, the VTA, the very tired addict, which is has to do with addiction and associated pathways, rewards, also the nucleus accumbens. So, since I just kind of mentioned jump into topics into addiction, I want to just give you a curveball. Addiction. The two neurotransmitters involved in addiction is uh, dopamine and GABA. Write this down because it may not be on the presentation. Addiction, dopamine and GABA, neuro uh, transmitters involved in addiction, GABA and dopamine. Write it down, please. Okay, and then you have your acetylcholine. This is a little bit less of a high yield, but it's worth mentioning. It's made in the nucleus of a Maynard. Maynard. Okay, so dopamine and GABA is involved into addiction. That's his love to ask you, oh, the where is the ADHD neurotransmitter? So you have DNS. Where is Tourette neurotransmitter? You have DNS. Where is um, ADHD? DNS. So there's three of them that are in the DNS: dopamine, serotonin, and norepinephrine. Okay. Now then you have autism spectrum disorder. We said DNS plus GG. Okay, write this down. DNS plus GG. Then we say now that addiction. Then you have two neurotransmitters. So you have the GABA and the dopamine. So this is a very, very high yield. At least we are kind of going by the disorder and adding the neurotransmitters involved. You need to know, please. Therapies. We're jumping into therapies now. So let me give you a scenario. Remember, scenarios are important. The patient is uncomfortable with sharing his issues in a group setting. Okay. So why you want to encourage the patient to attend group setting is because it increase interpersonal learning. So learning and from one another. So you want to encourage group settings while also encouraging individual sessions. So you want to kind of double tap the patient. If it's uncomfortable sharing his feeling, you want to still encourage group therapy because it provides interpersonal learning. Okay. Okay. So when you hear enmeshment, right? Think of this as a relationship involving two or more individuals with unclear boundaries, right? So think Think of this a working relationship that you have at work. If your boss and you, we don't have clear boundaries, it's likely that we step into a meshment situation with one may step on the toes of the other. So enmeshment is nothing but a two or more individuals with unclear personal boundaries. And this may occur when the client and the therapist are in sections, right? So ensuring that the therapist and the client have clear boundaries so that they facilitate the interview process. And this can happen with counting transfers. Counting transfers is when the therapist transfer his or her feeling to the client. Counter transfer, it's the therapist to the client, and transfer is the client to the therapist scenarios. Now, what is cognitive distortion? Cognitive distortions are irrational thoughts patterns that can lead to negative thinking and can contribute to mental health issues, exacerbating anxiety, depressions, or examples, right? Here are some here's some cognitive distortion. Make sure you know labeling and mislabeling. Why? Well, labeling and mislabel really affect self-esteem. It damage self-esteem. So cognitive distortion, two to know. There are too many to list, but I picked two. Labeling and mislabeling. It attaches a negative label to oneself or other based on one instance or event. So, for example, if you say that your car worker is late, and then you are attaching the labeling of a lazy person, so that labeling now affects your coworker because she or he was late once, and you say, "Well, that's a lazy person." So you are labeling and mislabeling somebody else. Another example is catastrophizing the situation, making things way worse than what they are, or jumping to conclusion. So let me give you a worst scenario case. Let's say I have an assignment to school, and the assignment says that, hey, if it's not due by X date, you lose 10 points. So the maximum points that I can get for the assignment is 90 now, which before was 100. It doesn't mean just because it's late, I'm going to fail the class, right? Hopefully not. That should never be the case. But it should be a point deduction for not turning in the assignment on time. When you're catastrophizing, you'll be like, oh my God, this is the end of the world. I'm not going to pass the class. I'm going to be kicked out of school. My parents going to be so disappointed. While some of this may be true, most of the time it's going way above what the normal person would expect, the reaction. So that's part of a two example of cognitive distortions. There are more, there are many more, right? Now, when we say cognitive therapy or behavior therapy, these are two different types of therapies. Same slide for easy understanding. Cognitive therapy is not cognitive behavior therapy. Cognitive behavior therapy is one separate entity. Cognitive therapy is one separate entity, and behavior therapy is one separate entity. So there's three types of therapy. So starting with cognitive therapy, okay? So it aims to replace the negative distortion with the positive thoughts. The focus to identify and challenging the negative thoughts pattern and replace them with the more realistic positive ones. For example, if someone is walking down a hallway and don't see me, right? My initial thought to be like, this person doesn't like me, when they could possibly be not it. It could be that the person was busy or didn't see me, right? So I'm replacing the negative thoughts with, okay, maybe the person didn't see me. So this is a thought process in the individual can improve their emotional well-being and overall mental state when they replace the negative thought with a positive one. Moving on to behavior therapy. If Cognitive therapy is the thought, the behavior therapy is the action. Now, the behavior therapy, I'm going to learn coping techniques, do skill trainings, the behavior of role playing, the behavior of exposure therapy, or being exposed more often to the things that I am uncomfortable until I get better, modeling, problem solving, and relaxation. These all behaviors type of therapy. So understand the examples given are so important. For behavior therapy, you can do coping techniques, skill trainings, role playing, exposure, modeling, problem solving, and relaxation. Now we come to a CBT, cognitive behavior therapy. So now it's the two therapies that we mentioned here combined, you get the best of both worlds. You get cognitive behavior therapy made by uh, Beckman, right? So it's the combination of cognitive and behavior therapy. If the question asks you something about cognitive and behavior together, then CBT is the likely choice. Is one of the best answers because it's an umbrella answer. So, example of CBT you need to know. Journaling helps with CBT. Journaling helps with CBT. And cognitive restructuring, right? Replacing a negative thought, the irrational behavior, with a positive one. Humanistic therapy, okay? I don't know if this helps you, but it helps me. When I hear humanistic therapy, I want Mr. Roger, right? Wants to be the good neighbor, something along those lines. I always think of humanistic therapy. I think about Mr. Roger, right? So, so Mr. Roger here is Carl Roger, right? And he believes in person-centered approach. He believes in self-directed growth and self-actualization. So, what is that? Well, if you look at the Maslow hierarchy of needs, all the way to the bottom, you have the food, shelter, safety, housing. And all the way to the top, you have exactly that. You have the personal growth. If I have food, water, safety, shelter, now I can think about being a psychiatric nurse practitioner. And now I can think about being the CEO of the next 500 Fortune company, right? Because my basic needs are met. So the humanistic therapy made by Mr. Carl Roger emphasize self-directed goals and self-actualization. Okay, so it's also known as the person-centered therapy. So it's all about the person. It believes people are good and naturally good. People are believes that people are naturally good. So Carl Rogers, and I put a very few people names on my presentation. So this is one that you need to know, right? Carl Rogers for humanistic therapy. It's believe in self-directed goal and self-actualization and believes people are naturally good. This is a person-centered therapy. Okay. Now we're moving on to interpersonal therapy. If you hear interpersonal therapy, think a bit about uh, cap- couples dispute. A husband and wife is fighting. So this is not the same thing as marriage therapy, but it's very close related. If there is a dispute between two parties and they're trying to resolve the issue, even if it's husband and wife, I want you to pick interpersonal therapy. Do not pick couples therapy. It may not even be in a choice because they're very closely related, but interpersonal therapy is high yield. So it addresses distress causing interpersonal issues, resolving relationship difficulties, marital status difficulties, right? It helps to find the missing link why one person is not getting along with the other. Now, since we are talking about couples and couples therapy, I want to just point in something that's not part of the interpersonal therapy, but I'm putting the same slides. Too many points to cover, right? I don't want to make 1,000 slides, but think about this. Example is that you have a couple therapy. Now, this is specifically couple therapy, not interpersonal therapy. You have a couple therapy, and the wife shows up alone. Okay. In this example, your action, your priority is to reschedule the counseling session. Why? Well, this is a couple therapy. Excuse me. It's a couples therapy, so it's not an individual therapy. If both of them are scheduled to show up, your action is to reschedule. It's not to see the one person and and see the other separately. If it's both of them to be seen together and one didn't show up for an appointment, I want you to think of rescheduling being the right answer. Okay. Now let's move on to something that's often people have a lot of trouble, which are the family therapies kind of realm. But this one is called the multisystemic family therapy. Multisystemic family therapy, also known as MST. So, what is a MST? Think of the MST, multisystemic family therapy, for children and adolescents between age of 12 and 17. Those kids have behavioral issues like conduct disorders. So, multisystemic family therapy are for those adolescents that have behavioral issues like conduct disorders. Think of a little jail for for adolescents. I'm not making fun of the little kids, but I'm just trying to find something that you can associate with, even if it's a funny analogy, so that way you remember. So when we say multi-systemic family therapy, we are talking about adolescents between the age of 12 to 17 with conduct disorders like patterns, right? So they have uh it is like when the child has a antisocial behaviors. I'm not saying that they have antisocial personality disorder, because that cannot even be true. For one to have any personality disorder, they must be older than 18 years old. I'm saying symptoms or traits. Okay. So now, why is it why is it a good choice for those patients with conduct disorder traits? Well, because it allows the parents empowerment. So we equipping the parents with the necessary resources and skills to deal with those adolescents. So the goal of multisystemic family therapy is to involve the family and allowing the parents with resources and skills. So you want, the objective is to minimize oh, obstacles hindering the families from getting help, right? What do you need that we can help you with? The focus area is to tackle common hindrances like stress and substance abuse. So if those are stress and substance abuse is interfering with the family, with the how the kid is reacting, so we want to address those issues, right? The recommendations for youth with antisocial traits or conduct disorder. Okay, very important. Look at what the objective of empowering and helping parents with the necessary skills to minimize obstacles of the families from getting help. Now let's go strategic family therapy. Okay, so few things to be mindful of strategic family therapy. It is solution focused, problem focused. So strategic is solution focused. It involves three main techniques. It involves paradoxal instructions, straightforward directives, and reframing. Strategic family therapy use paradoxal instruction, which is to be used cautiously, very cautious. Because if you tell the husband to go home and start fighting the wife, you using paradoxical instruction because that person has a hard time doing what he is supposed to do. So you tell him to go home and start yelling at the wife. What he's gonna do is go home and not yell at the wife. It's a paradoxal. So it's going against the directions for those that have difficulties following the directions. You can also use straightforward directive. So that's very simple, right? So aims to enhance the patient's self-awareness, ensure compliance with medications, or alleviate the fear of failure. So straightforward is nothing but utilizing a clear, direct guidance. That works well for those that follow guidance. That's also part of a strategic therapy. And last thing to be mindful is reframing. So the change the person perception by explaining a situation in a different context. So this allows the patient's belief system by reframing negative thoughts into positive ones. For instance, interpreting a child's jealousy towards a sibling as a sign of caring for the younger sibling. So, example here. In the strategic family therapy, the younger boy says, I hate my little sister. And how would you reframe in a strategic family therapy? You reframe by saying, no, you do not hate your sister. In fact, you love her very much. And for that reason, you are concerned about sharing your parents' love. So basically, I'm saying the same thing in a reframed way. This is a good example. You should write it down. So you do not hate your sister. You actually love her very much and you love your parents very much. So this is how you would use reframing for strategic therapy. Solution focused therapy. Now we are going to employ, deliver something that has been used in the past to tackle current issues. So, for example, if I lost my job in the past, and I say, well, in that past, when you lost your job, what did you do? Well, I went to the newspaper and I found a job. Let's say this was the example. Okay? So I'm going to employ something for solution. I'm going to employ something that worked in the past to create a solution for the problems that I'm having now. So it utilizes miracle question, exception questions, and scaling question. So solution, well, strategic, right? Strategic use paradoxal, straightforward, and reframing. Solution focus and problem focus. So strategic, problem focus, solution focus, paradoxal, straightforward, and reframing. As we move on to solution, we want to utilize something that was used in the past as a solution that worked. We want to use three strategies: miracle question, exceptional question, and scaling. So, miracle question. So, you want to explore the desire for future states, right? For example, if you woke up tomorrow and a miracle happened so that you no longer have this problem, what would be the first sign that you would tell your life that has suddenly improved? Okay, so mirror question. If you didn't have the problem, how would that feel? So exception questions is something like, tell me about the time when this problem did not happen. When you are doing differently during those times? What did you do differently? Okay. Then the scaling question is like from 1 to 0. 0 is the worst problem ever. 10 is the completely problem is resolved. Where would you say you are now? So for solution, you use miracle, exceptional question, and scaling question. All right, we knocked three of them down. So there's a lot of family therapy. Now we have the family system therapy or the systemic family therapy. They are one and the same, different names. So here I want you to know they have triangle, triangulation, self-differentiation. Self-differentiation is very important. And geograms. Geograms also used in structure, but most important, triangle, triangulation, and self-differentiation. Now here, let me tell you something that people get often confused. Triangle and triangulation is good. The goal of systemic or family system therapy or systemic family therapy is to develop self differentiation. So, what am I talking about? Well, when self differentiation is I am part of my family and I have a role in my family, yet I am an individual that I have my own differentiations from my family. So, the goal is to develop self differentiation. Now, to the unclear part is how is triangle or triangulation good, right? So, triangle is also known as a three-person relationship. Considered the smallest stable relationship unit when there is a tension or conflict between two people, they may have a triangle as a third person to reduce the intensity and anxiety within the diact. So it's like, let's put this way, the triangle. Let's say I have a group project, me and you, and we are bouncing, back and forth, and we can't agree. So we're stuck, right? Or either I'm going to overpower you or you're going to overpower me, but something is going to happen, okay? Now, when we have a group with three people, if I don't agree with you and you don't agree with me, we can always go to the third person. That third person can help solve or give an input for a possible action. Now, is it always good? No, it can be bad too, right? So the third person might be another family member, friend, or even a concept or object used to distract from the original issue. While this can provide a short term stress relief, it can lead to complex relationship patterns that hide in communication and self differentiation, which we said was self differentiation, the goal of systemic family therapy, right? Within the family over time. So, triangles can perpetuate dysfunctional dynamics, and identifying these patterns is essential part of the systemic family therapy. So the triangulation can be good, but can also be bad. All right. The goal of systemic family therapy is to have self differentiation. Right. Triangles helps decrease the anxiety. It can help with decrease the anxiety. So, structure family therapy. Now we are talking about structure. I want you to think of the military, right? So, structure family therapy use hierarchies, ranks, boundaries, and genogram. So, example of family therapy session that includes hierarchy, boundaries, and trying to facilitate the boundaries so that they are more clear and genograms. So the therapist first explains the importance of a family structure, hierarchies, and boundaries. So people are not stepping on each other's toe. This process they establish boundaries between different generations and branches of the family and between individuals. So establishing boundary is a good thing. By recognizing these dynamics, the therapist guides the family towards developing a healthier boundaries, more balanced hierarchies to improve their functioning as a unit. So it does make sense, right? When we have unclear boundaries or we don't know the rules, we often make mistakes, and sometimes it's not meant to be that way. It's just that we don't have the boundaries, we don't have the hierarchy. Who's in charge, right? Who's in charge of this family? So now, the structure family therapy use geogram or mapping of hierarchy to show the client the hierarchies and how things are currently working within the family and how power is distributed. It can also use joining. So the therapy joins the family through the empathy, understanding, through the continuum interaction. It uses enacted or role playing for dysfunctional interaction identified through role playing scenarios, and use reconstructory boundary making. So most important is geogram, boundaries, and restructuring, right? Having the family adapt clear boundaries so the family can adjust the hierarchies as needed, right? Right. So we want to recap this because this is so important. Family therapy, people get confused. I'm going to recap this again very fast. So family, I mean structure, we use genogram, joining, role playing, and restructuring. Backwards, structure therapy, right? Again, they use hierarchies and genogram and boundaries. Think of the military. The family system therapy use triangles. Triangle is good. They serve to decrease the stress, self-differentiation, and can also use genograms. Um, that's the family solution. Use the solution that worked in the past. They use three things: miracle question, exception question, scaling questions. Strategic solution focus, problem focus. Use three strategies: paradoxal, straightforward, and reframing. Mood systemic family therapy, younger adults, youth, 12 to 17 usually. It's often used for conduct disorders, and the goal is to equip the parents with solutions or in stopping of identifying if behavior issues, especially substance abuse and like, are hindering the process. So just like that, we had their family therapies broke down. Hopefully, you remember those keywords. They are very important. I would write them down and kind of memorize them because they can be very confusing, right? So I just want to recap because this is likely to have a question on family therapy. Okay. Now, elements of mindfulness. Mindfulness is nice. I love it. So it brings you to the present. So if you're anxious, you live in the future, now it brings you back. The techniques such as deep breathing and awareness of body sensations, thoughts, and sounds. So that's mindfulness. It's important? Yeah, should know. So as we move on to reflective practice, when do we do reflective practice, right? So we do that during a debriefing session to analyze unsuccessful results, right? So we do a reflective practice to debrief a session that went wrong. Someone passed away in a way that should not happen. So we do debriefing. What has happened, right? This aims to enhance future performance, right? So reflective practice is a good thing, and debriefing is the technique used. As we move on, legal concerns with telehealth. Telehealth has become a stronger modality for doing therapies and employing much more since 2020s. So the concern here brings a lot of concern. One is patient confidentiality that can be breaking, right? Can be broken. Potential for mistake medical care, and obviously licensures uh, issues. If someone is in Texas and it's prescribed to someone that's Maryland, it may not be ideal in this state dictated, right? All right, psychiatric service expansion, right? So we have noticed that the OB clinics now they may have a psychiatric nurse practitioner, and we are doing this to improve the psychiatric service to the panels. The goal is to increase mental health access to people who need it the most. So the goal of adding psychiatry service to medical service is to increase mental health access to the people who needs it the most. Example, OB provider plus a psychiatric provider. Older adults, older females, in this specifically example here, older adults or post uh, menopausal women, they may report lower libido. Why? What's the cause? It's often related to two things: low testosterone level and decreased blood circulation to the pelvic area. So if you have an older female that's complaining about low libido, medical cause can be due to the low level of testosterone and low level of blood circulating through the pelvic area. Now, women in general may have a less they can handle alcohol usually compared to a male of the same weight and height. uh, Less alcohol can be more intoxicating to them. Why? Because they have a higher susceptibility to be intoxicated due to a reduced alcohol hydrogenase, right? So they have a lower level of alcohol hydrogenase, which breaks down the alcohol. So the alcohol is in the body for a longer time, increasing intoxication levels faster than males, generally speaking. Okay. So they have an increased risk of liver related alcohol consumption, right? Liver damage issues due to the increased levels of intoxication due to the alcohol, lower alcohol hydrogenesis, which breaks down the alcohol. Super important. Okay. You have to write it down, every single example, guys. As we move on, I know there's a lot of information, especially today's event recording, because it's a lot, right? Reflex. Let's talk about some reflex. The palmar or the grasp reflex. It is normal between 5 to 6 months old. So what is it? Well, have you had an infant, right? That 5 6 months, you give them your finger and they goes right? And holds tight to it. So that's normal, right? If you have this that persists up from, older or 2 years old, then this becomes abnormal. It should not be there, right? The modem or startle reflex is the one in which you throw the baby back, it goes, the arms fins out, and it's kind of like the modem. That's normal up to 5 to 6 months. Now, the Bambinski or plantar reflex is normal up to 24 months. But if it doesn't, after that, it could be a spinal cord injury of some kind. So it should be, it should not go, it should, after 2 years, the toe should go inwards, not outwards. Okay. So the toes should be going inwards rather than outwards. Okay, so if it does after 24 months, then it is it can be a problem, right? So it's not a normal reflex. ADHD and substance abuse. When applying the relationship between ADHD and substance abuse, you can do this in two ways. One, it can be a straightforward, which you screen all adolescents to identify ADHD symptoms, right? You identifying those adolescents at risk for substance use based on their ADHD symptoms. That's the straight. Or you can do backwards by identifying adolescents with substance use risk to identify uh, folks with ADHD. So, two ways to do that: substance abuse and ADHD. You can use the straight, which would be the ADHD, to find out about substance abuse, or you can do the backwards, people with substance abuse, to find out those who have ADHD. Okay. So now I want to kind of talk about a scenario here. That's not necessarily ADHD, but a scenario in which one works at the hospital. Let's say you work in a hospital, right? And the patient is inpatient. So when would that person be ready for discharge, right? So the discharge starts the moment the person is admitted, the discharge process. Now, one, I wanted to think about, when does the person ready to be discharged? When the person has shown an increase developing coping skills, they are ready for a less intensive setting, and when they are not blaming others. If the person continues to blame others, for example, Well, I felt suicidal because my girlfriend decided to break up with me. So I'm blaming someone for my suicidal behavior. So therefore, I'm not ready for discharge. So when the person has developed coping skills, like, well, yes, I was thinking that was the end of the world. Now I know I can take a minute, take a deep breath, and continue on. And I am responsible for my own behaviors and attitudes and outcome. So I'm showing capacity to be discharged. Okay. So not necessarily related to ADHD or substance abuse, but when to discharge someone, discharge initiate the moment depression is admitted. Discharge is part of a continuous assessment, and the patient shown increase in coping skills and taking actions for their taking taking not blaming others for their faults. So that means they are ready for discharge. Now, acupuncture and depression. So has been shown to improve patients' pain perception. They may have a pain reduction with acupuncture. Acupuncture. So if the patient comes to you and say, "Hey, I am taking this medication. It hasn't helped me, and I would like to switch to acupuncture." So your role is to respect the patient's choice and provide education. Your role is not to say, "Hey, in my experience, acupuncture has not been shown to decrease anxiety or depression or relieve pain. I think you should be on this medication." So no, 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 no. Your goal is to provide and empower patients with solutions. If the patient wants to go acupuncture and you know that acupuncture has been shown to be a possible option, so you provide psychoeducation and you encourage the patient to, to find a good practitioner that does acupuncture. Now, law cases, I want to talk about habeas corpus. Well, what is the habeas corpus and why do I need to know? Well, it's a legal principle that allows patients to live against medical device that protects the patient against unlawful hospitalization. So all the patient needs to do and say, "I want to invoke my habeas corpus," right? And if this is an inpatient and the practitioner says, "Hey, you cannot," inpatient behavioral health, right? "You cannot leave because you are serious danger to yourself or others," then they would schedule a court appearing so that the patient can leave if necessary, right? Can leave against uh, medical advice. Unrelated again, let's talk about disseminated encephalopathies. So, uh, so disseminated encephalomyelitis, okay, is a neurological condition that characterized by a brief but widespread attack of inflammatory swelling in the brain, in spinal cord, that can damage the myelin, causing paresthesis, weakening, fatigue, asymmetrical body movement of the extremity. So here's the thing, right? We don't like to refer, we prefer never to refer, but if you encounter a case that's specifically medical related, then that's time for referral. However, you always do something when possible before and refer. In this case here, your priority action is to do a neurological exam. You do a neuro exam before you refer, right? Before thinking about referring, ask yourself, can I get a lab? Not specific to that situation, but can I get a lab? Can I do a neurological exam? If that's the answer is yes, then most likely that is the the right answer choice. You're a higher level provider now at this point. You initiating your practice, so we want you to take action rather than referring. Unless if it's specific case like Rediton, you refer. OB cases that are complicated, you refer, and so forth, right? Now, research is super important. Think of the research, what the PICO question means. The P is for the population, I for intervention, C is for comparisons, O is for outcome, and oftentimes we want to see how long the time frame. Okay. you need to know your PICO question. And right along with PICO question comes your levels of evidence. So if you look at the pyramid and you have a level of evidence, you see the highest level is the systemic review or the meta-analysis, right? There is one is not better than the other. They're both the top, the best, followed by evidence obtained from at least one well-designed RTC, randomized control trial, right? So when we do RTC, remember that we want one set of patients to get the intervention, we want the others to get the placebo. So that way we can compare those that got the intervention to those that received the placebo, how well they did. And that's why kids are unlikely to participate in, in studies because, well, if you want to, if your kid has a major depressive disorder, do you want the kid to receive a placebo or a real medications, right? And we don't know. This is a randomized, so that's why kids often don't participate on those treatments, right? Now, how do you change your practice? You always change your practice by collecting or looking at current journal articles. Changing practice must be done with evidence based support by current journal articles. Okay. Now, let's say that you want to gather insights from colleagues in different clinics, different states. You can do this by setting up a digital forum or initiate a questionnaire. You can gather insights from your colleagues across different regions by setting up a digital forum or a initiate a questionnaire so you can collect data. So think of this as collection of data, as assessing. Okay, not necessarily related to research, but just saying that if you need to start a project and one works in Ohio, another person works in Minnesota, another person works in Florida. It's unreasonable for you to travel to each location, but you can do a digital forum or initiate a questionnaire to gather the information that you need. Okay. Now, when enhancing policy, right, or policy implementation, how can you get the buy-ins in, right? You cannot move something alone by yourself, so you need the buy-in, right, for this policy. Let's say you are trying to initiate a policy on medication management. Okay, you do this by highlighting its roles in elevating the standard of patient care. Okay, so by showing the benefits to improve the quality of patient care, you get in buy-ins. By showing this is good for the patient, is good for the business, you get the buy-in in this way. Now, tools to track patient outcome, right? Here I'm more specifically talking about scales in psychiatry. So you want to utilize the scales to drive quality improvement for mental health conditions such as depression. So we use the PHQ-9 to assess the patient now, 6 months from now, a year from now, so we know if it's improving or decreasing. Okay. So we use these scales to measure the intervention provided and measure the patient's outcome. So with implementation and the standardization of scales to record the initial patient evaluation and follow-ups to set up throughout the therapy, right? So we use the scales to determine the baseline score at regular interval during the treatment. So scales are very important. When would you use anchoring questions? So let's say about that you are interviewing an older adult, right? And the older adult, you ask questions like, okay, last year, where did you travel? And it goes like, wow, man, I can't forget. You can say, I thought you said you went to a warm state in December. Was it Florida or Hawaii? So something along those lines. Yeah, I was at my daughter's wedding in Hawaii in December. So use anchoring questions to retrieve or help the patient with recalling a timelines of their symptoms. In this case, um, did last week, how did you feel last week? Or, if you ask a question, hey, when did your symptoms start? And the patient said, oh, I don't know. You can say, how did you feel last week? You know? So, so you can use the recall or anchoring questions to help patients memorize or come back in a timeline to help the patients identify their symptoms. Now, patient privacy in social media, right? So you should never look a patient up on social media, online, because in doing so, you are breaking the trust. Okay, you breaking the trust, you breaking that privacy. So no searching for patients' information on social media, right? That's a no-no. Okay, when it comes to conflict of interest in healthcare. We know that pharmaceutical companies can provide patients, or not patients, us healthcare providers with incentives. So anytime you have incentives of a pharmacological company offer something for nursing, for doctors, for example, if you prescribe my medication or if you refer my medication more often, I'll pay for your tuition, right, cost. So in return, the nurse must prescribe the company's medications more frequently. This is a conflict of interest known as the Stark law, right? Which is illegal. It should not be done. So there is a problem here. So you want to develop policies to mitigate this conflict of interest. Okay, you need to provide a policy if you need to mitigate this as a conflict of interest by creating policies that aligns against this practice if you must. Okay. Now, what is tolerance and what is sleep apnea? So, again, making one slide for each of those conditions is not really appropriate, but I want to talk about two different topics in the same slide here. Tolerance. You need to know the definition of tolerance. You need to know the definition of addiction. You need to know the definition of all those things that comes with substance abuse. But most important, what is tolerance? Tolerance of a drug or medication refers to the diminished response to a drug over time. If someone took benzodiazepine, like one benzo, when initiated the treatment, now it requires three benzos. So, of the same medication means that the patient has developed tolerance. Okay, it occurs when the body becomes less responsive to the medication, necessitating a higher dose in order to achieve the same therapeutic effect. And this can be through drugs and alcohol and even medication. For example, if the patient is taking an SSRI, 50 milligrams of Zoloft, and the patient is doing well, and then after a year and a half, the patient may need an increase to 100 milligrams because the body has developed a tolerance. Okay. Now, sleep apnea, totally unrelated in a sense, right? Unless if you were talking about alcohol, can also uh, affect the sleep apnea. So other things that can affect the sleep apnea is weight, obesity, diabetes, high blood pressure, narrowing of the airway, and smoking. So things that can worsen sleep apnea is excessive weight, obesity, diabetes, high blood pressure, narrowing of the airway, and smoking often does not help those patients with sleep apnea. Okay. Scales. So this is important. This is a lot of information and we're going to go over very slow here. So let's talk about two important scales here. Hopefully you can see this really well. I'm enlarging the screen. The MMSE, right? So when you do an MMSE, you're looking for cognitive impairment. You can use the MMSE which is not in the public domain. That means you have to pay for this tool in order to use. It's 0 to 30. Okay. Now look at the SLAM, which is the St. Louis uh, equivalent, St. Louis University, that created this tool. So the equivalent to the MMSE. Now this is publicly available. Both of the scales is 0 to 30. Higher numbers are better, worse, lower numbers are worse. Here we have the SLAM and the MMSE. So here we have those that are normal from 25 to 30. Below that, then you have mild cognitive impairment in the MMSE, and below 10, it's considered severe. The SLAM, 27 to 30, and then you have mild, 21 to 26, and 20 and below is considered severe. So those scales are super, super important. You need to know the MMSE, and you need to know the SLAM, okay? And know that higher numbers are better, lower numbers are worse. As we move on to depression, right, there are 3 scales here that you need to be aware of. Okay, so you are evaluating the severity level of those patients for the HAM-D, PHQ-9, and the Beckham score. So we start with the PHQ-9. The modern level is 10 to 14. Okay, the HAM-D, you add 4 points to that, so you get 14 to 18, and then you Beckham, the modern level is 19 to 29. Okay, and then you kind of can adjust. I would not recommend um, that you memorize each of those numbers because it can get confused. But I want you to know this, that if the severity level of any of these scales, right, especially for impressive scales, the 3 of them, the MD, the PHQ-9, and the Beckham, if it gets to, let's say, 21 on the PHQ-9, so your action is not to increase the antipsychotic. Your action here is, your priority is to assess for suicidal ideation. Okay, so if the HAM-D is 19, which is the severe level, your action is to assess for suicidal ideation, your priority. Okay, or the Beckham, 30 to 63. Now, as we move on to anxiety, you have GAD and you HAM-A. As you notice, the GAD is the same level as the PHQ-9, 10 to 14. So that's one stone and 2 birds. So that's your moderate level for the PHQ-9, and the GAD is 10 to 14. The HAM-A, which is the anxiety, so it starts where the HAM-D left off. The HAM-D is 14 to 18 now. It starts at 18 to 24. Okay, so how do I memorize all these? You can find a way that works for you. Okay, but let's start off this way. We know that the MMSE and the SLUM, they all start with 0 to 30. Lower numbers are worse. We want higher numbers. Okay, now let's talk about these 5 other scales. I make a little ways to memorize it, and I do this by creating a story. However, it's comfortable for you, however you feel that it works for you, that's fine. I'm going to show you my way. So my way is to say that I had a grandma. My grandma, she was born in 1929, older lady, right? She was born in 1929, and she had depression and anxiety. She did her own PHQ-9 and GAD 7 and the GAD scale. Sorry. So her score was always between 10 to 14 for both PHQ-9 and the GAD scale. But she was so stubborn and she wanted to really verify with other scales. So she used the HAM-D, and she knew it that by adding 4 points to it, it would be modern as well. So if her PHQ-9 was 10 to 14, she added 4 points. She got moderate scale 14 to 18. Well, from that, she really want to do the HAM-A scale for anxiety. So she added 4 more points. So where she left over from 14 to 18, the HAM-D, she added 4 more points. Now she is 18 at 22, really. But he is 24. So by making an assumption, she was born in 1929. She did the PHQ-9, and her score was always between 10 to 14. If she wanted double check with the HAM-D, she had the 4 more points, was 14 to 18. If she want to do the HAM-A, she had another 4 points, and she was 18 and 22-ish, but he is 24. Okay, so making a way for you to memorize the the medium values help you to adjust according to the question, knowing that your action, your priority action, is to assess for suicidality if the scale is above 23. Okay. Now let's take a look on the CUA scale and the CAUSE scales. Do not confuse CAUSE with CUA. Okay. So the CAUSE score, right? You have between 5 and 12, you give clonidine. If the score is more than 13 or 13 and above, you give two medications, buprenorphine or Suboxone, right? So if the score is mild, between 5 and 12, you give clonidine. If the score is higher or equal to 13, you give buprenorphine or Suboxone. Okay. CUA scales. You need to know the components of the CUA scales. I don't have it here, but you need to know the components of the CUA scales. Okay. And you need to know the when to give what for the CUA scales. For example, if the CUA score is 8 and more, you give only a PRN medication. If the CUA scale is 8 and more, you only give PRN. So your two choices for PRN are Valium and Ativan. And by the way, you don't have to memorize diazepam and Valium, and same thing as Valium, lorazepam, same thing as Ativan. Because on a test, they'll give you both names. So if the person does not have a liver disorder, you're fine with giving Valium at 8 or more as needed only. If the score increases to 15 or more, then you're going to give schedule Ativan plus a PRN medication. Okay. If your patient has a liver problem, you no longer give Ativan. You no longer give Valium, you give Ativan. Why? Because of a shorter half-life. Okay? So understand, PRN is 8 or more. As the score reaches to 15, now you give PRN plus the schedule. Now, let's take a look on the depression scales here one more time. Well, we said if the severe range, your action is to assess for suicidality. What if it's mild? Then your action here is to offer therapy or nothing. If it's moderate, you can offer medication therapy or a combination of both. Severe, your action is not to increase the medication, it's not to switch the medication, but to assess for suicidality. Mild, you offer therapy. Modern, you can do therapy and or medication. Okay. Another scale that often comes back is the Edinburgh postnatal depression scale, or EPDS, is recommended for screening of those patients with postnatal depression or depression during pregnancy. So this is a perfect example for collaboration. When a patients are being discharged from the OB floor, you notice, this is an example, so shouldn't write down, you notice that patients are being discharged from the hospital without being assessed for mental health condition, in this case, depression. So you can collaborate. So the deal here, the keyword is to collaborate with the OB department so that they can have a scale in place, whether it's a PHQ-9 or the ED EPDS scales, right? So you want to collaborate as the keyword to have those patients being assessed after before discharge. Okay, you can use mnemonics or visualize the graph to help you understand this, but every single line here is important. Okay, so just few minutes we went over the MMSE, which is not in a public domain, you must pay for. The Islam, it's in a public domain, you don't have to pay for. Use those scales for cognitive impairment, most of the time dementia. We went over the PHQ-9 and the GAD, the same score. We said 4 more points, we'll get to the HMD. Beckham, my grandma was born in 1929. Anxiety is just 4 more points than the HMD. We talked about cows, mild between 5 and 12, we'll give clonidine. More than 13, we have an option to give bunopropion or Suboxone. Okay. If it's CO scales, 8 or more, you give only PRN. If it gets to 15 or more, now we give PRN plus schedule. Right? Two options for medications for alcohol use withdrawals. This is not alcohol use maintenance, right? This is alcohol use withdrawal. You can give Valium or Ativan. You give Ativan if the person has a liver condition. How do you know if the person has a liver condition? You look at the ALT, AST. Mild for depression, you give nothing or therapy. Moderate, you can give therapy, medication, or combination. Severe range for depression, you assess for suicidal ideation. You want to collaborate or use the Edinburgh postnatal depression scales for those patients that's postpartum or currently having depression symptoms during pregnancy. Okay, so this was a quick, short review on the scales. We went in depth on our 30 days PMHP walk to success, but here we are reviewing them kind of quickly. What are the signs and symptoms of withdrawals in which you could give Ativan, right? Or you can give Valium. So you can use lorazepam or Valium in this case, right? So um, signs and symptoms of alcohol withdrawals include tremors, paradoxal sweat, so that's the 9 times sweat, tactile disturbance, hearing things, seeing things, or even having feeling that bugs crawling on the skin. These are symptoms, classic symptoms of alcohol withdrawals. Patients are at higher risks of alcohol withdrawal when they, pass the 48 hours. Now, let's talk about opioid dependence. Those that want to cut back or stop the treatment for, I'm sorry, not opioids, for alcohol dependence. Sorry. We have 3 medications. We can use a composite or naltrexone. Those help the patients with alcohol dependence. They have been shown to decrease the alcohol intake or curb the cravings. Dulsifrine, which is anti-abuse, okay, it's a medication that it's aversion therapy. Basically, if the patient digests anything with alcohol, 2 weeks after taking this medication, they will still feel it. So, in order to prescribe the dulsifrine or anti-abuse, the patient needs to have no alcohol for 12 hours since the last drink. And if they start on the medication, they need to have 2 weeks after they stop the medication in order to consume some alcohol. A composite and naltrexone has shown to decrease cravings for alcohol. Okay. Now let's take a look on some of the mediums of the MMSE, right? 10 to 20, the slum just about 10 to 20. So you kind of can make that easy memorize. I want to go back here, right? So if you look roughly here, moderate for the MMSE, moderate impairment, right? You can kind of say that 10 to 20 range. The doesn't have a quite modern for the Islam, but just want to make an association here. Okay. So if we look at the HAMD, right? So we got 14 to 18, PHQ9 10 to 14, a GAD 10 to 14. The Backham scale 1929, HAMD 18 to 24. Right? I want to emphasize if patient has depression over 18 HAMD or over 14 the PHQ9 or 19 or 29 for the Beckham scale, you assess for suicidality, right? If the patient has modern depression, right, which can be the PHQ9 or the HAMD of 14 to 18, medication and or therapy. If the patient has mild depression, right, you do therapy or nothing. If the patient has mild anxiety, you do therapy or nothing, right? If the patient has severe anxiety, which will be more than 24 for the HAMD or more than 14 for the GAD-7, you can do medication and or therapy and assess also for suicidality, right? If the patient has moderate anxiety, you can do medications and or therapy. So this was just a quick review after we went through the slides so we can kind of visualize in a different way. Okay, cows. I want to go back to this because I want you to know that questions could be if the patient has a score of 25, what would that be? Okay, so the score for the cows is up to 36. You know that mild, you give clonidine. When the patient hits the 13, you know that Suboxone or buprenorphine can be given. So that's modern. So then severe is over 36. So you have this 25 to 36 that's modern severe. So you need to know because they score, they can give you the score of 25, 26. Kind of use what you know that mild, 5 to 12, it's mild clonidine, 13 to 24, it's moderate. I have two medications to give, Suboxone or buprenorphine. 36 is severe, and moderate will be 25 to 36. You need to know what the number is and what it does on this scale specifically. Okay? Test makers are known to ask about cows, and they give you a score and they ask you now what the symptoms are. Okay? So it's 11 item score is validated tool used to assess the severe of opioid withdrawals. Now, what are the opioid withdrawals symptoms, right? So these are symptoms of opioid withdrawals can be yawning, irritability, pupillary dilation, um, piloerection, which is goose pump, muscle aches, lacrimation, they're very tearing. Most important scales again for opioids, not important scales, but here the symptoms, runny nose, these are very important symptoms, sweating, insomnia. Now, alcohol withdrawal will kill. Opioid withdrawal does not kill, it's just terrible, okay? So don't get confused the cows with the CW score. Now let's talk about CBIRD, right? So when you use CBIRD is to screen for substance use disorder. CBIRD is for screening for substance use disorder. So the S is the screening, the B is a brief, the I intervention, R is referral to treatment. You use the audit score to determine the appropriate intervention per CBER protocol. You can use the cage to identify what the score is. And by the way, you need to know what the cage is. 2 plus on a cage means that there is a likelihood to have a alcohol related incident or abuse. You can use the drug abuse screening test, which is known as the DAST. It can be used for younger adults and adults. All right, guys. So this was it. Short and sweet. I know it was a lot of content, but I hope you enjoy this content. And just please remember that every single thing is important here. Every single things that we talked about is important. So I hope you the most success. Let's go on and discover the next video. PMHNP Crash Review with the NP Exam Coach. See you next time.